Hello, 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 hello. Happy Friday, everybody. Welcome to another version of VMR. Unfortunately, today, I will start off with the bad news. The bad news is that you'll be stuck with me solo. Why? Because Prof. Rez took a red eye to Pittsburgh yesterday because it is his partner's a thesis defense this week, and he is right now fast asleep. He might wake up, and if he does wake up and decide to join us, great. But based on his text message, I think the chances of that are very, very low. So instead, what we will do to fill the massive void is do breakout room, at least one breakout room, so you all get to hang out and get to chat with each other and share the collective wisdom of 50 people equal the wisdom of Prop Res. But speaking of partners, I'm thrilled today to tell you that we have the return of Dr. Kara Lau, uh, who is here presenting yet another case to us. And I think by now, those of you who have hung out in VMR know that in addition to being an epic case presenter, she's also the best wife in the world, and I get to hang out with her all the time. Right now, we're sitting, there's a wall that separates us. Usually there's nothing that does, but for the logistical reason of not being able to actually talk and mute at the same time, we're in different rooms. We both are co-parents of the craziest dog in the world, as she will certainly attest. But I will hand the mic to you, Kara, to say hi, and whenever you're ready, we can jump right in.
Hi, everybody. I was going to make a joke about this being KLR today, but I think it would hurt Reza's feelings.
Yes,
So,
definitely. No, this is RLR and only RLR. And the moment this ends, KLR takes space. By the way, I don't know if you can see my mom cleaning behind Kara in the door. It's a very action-packed house today. Um, anyway, oh, I forgot to make you co-host. I know nothing about this case except two things. That Kara was nice enough to dig up this case from a while ago, it seems, and that there are pictures involved. So your co-host, you should be able to share. And as a primer for everybody, since Reza's not here, I saw a bunch of other people just joined. Since Reza isn't here, please, 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 if you are able to, please be prepared to join a breakout room. We'll kind of do that in the middle of the case. And if you can, it's always better to join the breakout room and turn your video on and chat. But yeah, why don't we jump right in so we have plenty of time to do that.
okay, I'll give you the one-liner first. So, this is a 52-year-old woman, past medical history, significant for hepatitis B, hepatitis D cirrhosis, status post liver transplant in 2013, with recurrent fibrosis and cirrhosis of the graft. Now presenting with abdominal pain, distension, and AKI. That's concerning for kind of decompensated cirrhosis now with new fever as well.
Wow, I love the start. I think the context here is very, very key, and I think the context that we're getting is this patient's liver is compromised, and it's compromised for a very common reason, and that's hepatitis B, excuse me. As a quick primer, hepatitis D is a fascinating virus that can only cause damage if it coexists with hepatitis B. And there's two ways that things can coexist. The hepatitis B and D combination can occur simultaneously, and a patient can get co-infected with hepatitis B and hepatitis D. Or they can actually occur serially, where a patient with pre-existing hepatitis B gets superimposed infection with hep D. But the virological transmission of hepatitis D requires hep B to be present either simultaneously or sequentially. And so it's interesting to reflect on what that means for the patient's presentation. When a patient has hepatitis B and hepatitis D simultaneously at the exact same time, the disease tends to be less severe than somebody who is already having hepatitis B, who then gets hepatitis D superinfection. And so it may not be relevant to this case. It probably isn't, honestly, but it's always helpful to know, was the hep B and hep D simultaneously acquired? Now, what's different about the combo of hepatitis B and D compared to hepatitis B alone? It's that the disease tends to be worse. Um, and the rate of acute liver failure is much higher. The rate of progression to cirrhosis is much higher. And curiously enough, the transmission tends to be a little bit different too. So most patients across the world who have hepatitis B infection have it through maternal fetal transmission. The other main forms of mechanism of transfer of hepatitis B or acquisition of hepatitis B is through blood transfusion and also injection drug use. And the interesting thing about hepatitis D, especially in the United States, is hepatitis D has a strong correlation with injection drug use. And one of the main modes of transmission in adults of hepatitis D is through injection drug use. And so now we know that this person has been devastated by this disease, so much so that she even got her liver transplant. But unfortunately, it seems that the liver transplant failed, either because of the aggressive disease of Hep B, but it looks like maybe because of graft versus host disease. So we now have a patient whose liver is compromised and who's presenting with abdominal distension, AKI, and fever. And I think the frame that we take in a patient with cirrhosis who has these things is the frame of decompensated cirrhosis. Now, why do we take that frame? We take that frame for one reason. In a patient who has a very chronically vulnerable liver, whatever presentation or issue they have tends to be dramatically influenced by the fact that they have cirrhosis. So if you have an infection, you would normally present with fever, chills, and localizing symptoms of that infection. But when you have cirrhosis, what happens is the liver completely takes over. And instead of having fevers, chills, and localizing infection, you no longer have an immune system enough to mount a fever, so you often are afebrile. And you get confused from hepatic encephalopathy, so you often aren't able to localize your symptoms. And so you can think of patients with cirrhosis as essentially a black hole. And whatever you put in it will just be sucked right into it and camouflaged into that frame. And so I think that that's why we frame this as decompensated cirrhosis. And the evidence for this being decompensated cirrhosis is one, that the patient has cirrhosis, but two, that they have abdominal distension, which we can often assume to be ascites, but that's not foolproof. And they have so much shunting towards their liver because of the decompensation that they cause pre-renal kidney injury from shunting. And so I think that unless we get more data to tell us otherwise, we'll call this decompensated cirrhosis. And the question is, what are the causes for decompensated cirrhosis? And you can think of this in really, I'll just show you a visual since we have a little bit of time. You can think of this in two broad categories. Is there decompensation in cirrhosis because of an increase in portal pressure? Or is there decompensation with cirrhosis because of a drop in arterial perfusion? So here's a visual. The most common causes tend to be on the far right. There is decompensation in cirrhosis because of reduced flow going to the liver. And that can be because of increased portal hypertension from a portal vein thrombosis, for example, or reduced arterial inflow from the splanchnic circulation, like the mesenteric, celiac, and SMA, IMA, and celiac plexus. The reason you can have reduced flow is from vasodilation, like an infection, which seems to be the culprit here with a fever, or lack of volume from bleeding, like variceal bleed. This far right is the most common cause. You can also have decompensation because you stop taking things that were helping you maintain compensated, like your medications for ascites, your antiviral, or you can have dysfunction of the liver itself, not the portal circulation. And you can get dysfunction of the liver itself because of HCC, because the other disease that you have progressed, or of course, you can get any new superimposed insult. So I think this is the frame we're going to take for this patient, and the fact that they're febrile has this prioritized infection. So that would be the frame that I would be taking, but I would really want to make sure that we're not making any assumptions, and that the abdominal distension is not free air, that the AKI isn't glomerulonephritis, and those need a little bit of verification before we can confirm that we're on this path. But in vast majority of all comers, this is the path to take. So to summarize, Hep D really amplifies the disease severity of hepatitis B. In addition to the traditional mechanisms of Hep B transmission, Hep D really opens the door for injection drug use as a route of transmission. Decompensated cirrhosis is the frame we take in patients with cirrhosis because of the black hole effect of the liver, which tends to suck any issue and camouflage it with its own manifestations. So you really have to have a broad approach to patients with decompensated cirrhosis to entertain vascular problems, those that result in dilation of the arteries, those that result in volume loss of the arteries, and those that result in resistance to flow of the portal vein, like a portal venous thrombosis. And then finally, diseases of the liver itself, like the development of HCC, or the lack of control of the underlying disease process, like aggressive hepatitis B replication. All righty. I'm almost out of breath. Tell us more, please.
Okay, I am going to give a lot of data. So from the HPI all the way up until the first set of imaging in the EP. So she, over the past month or so, had been experiencing worsening abdominal pain and distension, and she felt like the pain was mainly over like the upper part of her abdomen. And she very specifically said it felt worse with twisting. Mainly, she also thought that it was somewhat constant, but didn't really go anywhere else. It kind of stayed up there. Um, she had no like subjective feeling of fevers or sweats or nausea or really anything else. Didn't have any dysuria or urinary frequency. And she was just jaundiced, but didn't really have any rashes. She did feel like maybe she was a little more short of breath with exertion, and that was limiting her mobility at home. She presented like this to her outpatient hepatologist, who then, in the setting of a new set of labs that showed an AKI to 1.52 from like a baseline of normal, said she should present to the emergency department. When she got there, she was like a little bit febrile to like 38, but the rest of her vitals were within normal limits. Her very initial labs just showed that creatinine to 1.5, no white count, a hemoglobin of 9.8, which was her baseline, and platelets of 118, which was around her baseline as well. Because of her symptoms, they attempted to find a window in the ED to do a diagnostic para, and they weren't actually able to find an adequate or a safe window. And so she was started empirically on ceftriaxone for SBP management, and she was admitted. To fill out a little bit more of her other history, the most important medications you need to know that she's on, she's really otherwise from like an oral diabetes medication, just on her immunosuppression, which is Myfortic 750 twice a day, prednisone 5 daily, and TAC 0.5 daily. And then she originally came from Southeast Asia, and she immigrated about 5 or so years before her liver transplant, and otherwise hasn't traveled recently, doesn't use any substances, currently isn't sexually active. And then her exam she was actually not particularly like in any distress. She was quite jaundiced and had scleral icterus. She had normal heart sounds, normal lung sounds. There was abdominal distension, but it wasn't tense. It wasn't particularly tender. There were no like concerning peritonitic signs. She did have, I'd say, +1 pitting edema to like the shins, and otherwise she had like a baseline mental status, no like neurologic deficits, no asterixis, no other skin findings. And let me see if there's anything else I can fill out on her lab. Her coags were, her INR was 1.6, kind of where it was hanging out. Her nothing else really notable in her lights. And then her liver panel, she had an AST of 43, an ALT of 36, alk phos of 214, p-billy of 6, and her albumin was 2.2. Her UA was totally bland. And then radiology results, she got a CTAP. She was down there that showed just post-surgical changes of an orthotopic liver transplant. It was a non-con because of her AKI, and so they didn't get a good look at her hepatoportal venous like system. And then it looked like there was a nodular contour of the transplant allograft, and some mild to moderate ascites, as well as splenomegaly up to 16.5 centimeters. And then some trace pleural effusions for what they were able to visualize of the lung basis. And that's the first set of data.
Super, super interesting. And I think, you know, you may ask yourself, like, is this workup kind of typical for a patient with decompensated cirrhosis? And I would say it's almost, but not fully, honestly. You ask yourself, like, how many times do we get CT abdomen pelvis imaging in patients with cirrhosis? And the answer is very little. We often are very happy with an abdominal ultrasound and tapping the fluid. And I think explaining why this case is different than most cases is probably important. And I would say that there are two very unusual features about her presentation as we take the first step of trying to say, is this appropriate to call this decompensated cirrhosis? But first, let's talk about why I think it's an appropriate frame. The first is that she has cirrhosis. The second is that she has ascites. And the third is that she has evidence of liver dysfunction with her bilirubin and her INR. And so all those things are suggestive that the patient has some form of decompensated cirrhosis. What are the unusual aspects that give us caution to call this decompensated cirrhosis? And I would say there are three of them, actually. The first is her fever. It's very, very unusual to have a fever in patients with cirrhosis because of how immunocompromised they are. And I think that that really heightens my concern that there's something sinister going on here. So much so that it's overpowering the liver's ability to dampen the temperature. The second is that she has abdominal pain. Most patients with cirrhosis have no abdominal pain. You might wonder, wait, isn't spontaneous bacterial peritonitis a cause of abdominal pain? And the answer is no. The vast majority of people with spontaneous bacterial peritonitis present with decompensated cirrhosis causing altered mental status, i.e. hepatic encephalopathy. And that's the last unusual feature, that she's not at all confused. Her INR is up. Her billy's up. She has ascites. All that insult, and yet not an ounce of hepatic encephalopathy is very, very unusual. So the fact that she has the ability to mount a fever, the fact that she's not confused, and the fact that she's sensing abdominal pain are all fairly unusual. When somebody is this sick from decompensated cirrhosis, enough to mount a fever and enough to have abdominal pain, they often are confused and slow and lethargic. And that's the fact that that's not a prominent aspect of her case, especially the lack of asterixis, to emphasize that, is fairly unusual. So now my mind is saying, well, hey, listen, let's be simple. Decompensated cirrhosis is the most common consequence of decompensation of patients with cirrhosis, but could she have an underlying issue that isn't triggering decompensation of her cirrhosis, but is manifesting in a hepatotropic way? So could she just have stable bad cirrhosis and she has an underlying issue independent of liver physiology that's causing her to mount a fever this high and causing her to feel pain, and that her cirrhosis is actually completely stable? What's the evidence for that? Her INRs at baseline, and her platelets aren't lower, her hemoglobin is stable, and she's not confused. It's taking a lot of like cognitive effort for me to vocalize why this case stands out. And I'm ultimately realizing it's just coming down to one thing. She's not confused. I'll say this again. When patients have decompensated cirrhosis this bad, hepatic encephalopathy often kicks in. It kicks in, minimizing any sense of pain that the patients feel. And the fact that she's not confused, doesn't even have asterixis, has me wondering whether this is her cirrhotic baseline and she has a separate condition that is not on our list for decompensated cirrhosis that is causing fever and abdominal pain. That's a hypothesis that can only take up more space if we thoroughly exonerate all the causes of decompensated cirrhosis. So what have we exonerated? We don't see she has developed HCC on her CT abdomen pelvis. Well, I'm sure we'll check her hepatitis B DNA level and make sure it's suppressed. We don't see an evidence of portal vein thrombosis. We don't see evidence of a GI bleed. And so what's left to exonerate is an infection. And the most important infection to exonerate is spontaneous bacterial peritonitis. So if this patient's ascites tap comes back negative for SBP, and she doesn't have another garden variety infection like pneumonia, like a urinary tract infection or cellulitis, then I think we can be even more confident that this patient has stable cirrhosis and has a syndrome independent of that cirrhosis. But those are the two threads that I'm following now. Well, there's a lot to process there. It'd be really, really interesting maybe to get the next aliquot, and then we'll go into breakout rooms. Cool. All right. What you got?
I think we should do this aliquot and then the next one with the picture we should do breakout rooms. I think we'll get the most learning out of that. So she gets admitted to the liver transplant service. And she, seems to get a little better to the point where she is able to be taken off ceftriaxone and put back on ciprofloxacin, like doesn't really fever. And then like 3 or so days into admission starts mounting quite high fevers, like 101.4, like 102.4. And this keeps happening, like, and doesn't really come down that much with Tylenol. And so she gets started on like the whole shebang. She gets like linezolid, Miro, and Fluke. And she gets recultured. And she kind of gets an infection, a further like deeper infectious workup. She gets a chest CT that shows like no evidence of pulmonary infection, but maybe like a juxtapleural nodule measuring like 4 millimeters in the left upper lobe. They say likely parenchymal node. They also note that she has unchanged like trace pleural effusions, but like not a lot of interstitial opacity or ground glass. And she gets like a CMV and an EBV PCR that get sent off that are negative, an HSV PCR that's negative, MRSA and C. diff that are negative, a comp gold that's negative. Her Hep B studies come back with a completely suppressed viral load, and a couple of days in, her cultures from like admission come back with 1 of 2 cultures growing just yeast. And so she's brought into micafungin in that setting, and ID is consulted. And then of note, she also describes like some pain behind her arm. Actually, I do have a picture for you guys right now. She has a continuous glucose monitor on her right arm that she kept in since admission, and they'd been using values from that to kind of track her blood sugars. And she was like, oh, it's like kind of painful around there. And so I'm going to just show you guys what that looked like. Okay, can you see? Yeah, and we can stop there.
Interesting. Can I ask, can you feel though? Are they palpable or non-palpable?
They are like almost like nodular. They feel deeper, like they're not raised on top of the skin.
Mhm.
They look flat, but when you run your finger over them, maybe you can feel something like underneath the
Understood.
skin,
Yeah, understood.
and it's painful.
I see it. Painful. Okay. All right. Ooh, super helpful. Wow. Okay. Alrighty. Maybe we'll let Shema and VJ take the screen over because there was a lot of data for folks to stare at. Um, I think can I just ask? I imagine that a paracentesis was done at some point. Are you saving that for later or can we assume that was?
They weren't able to get a para.
I see. Wow. Even with the ascites on the CT. Okay. Um,
No.
yeah, I think that's helpful. Trying to think of, okay, I'm just waiting for the picture. Yeah, thank you for putting the picture in. That's awesome. So I think we were left with one thing to exonerate as a cause of decompensated cirrhosis, and we found an important result. And that important result is the patient is growing 1 out of 2 blood cultures growing yeast. And just to confirm, that's the blood culture, right? Not the urine? Okay. So it's really, really important to ask yourself what kinds of fungi grow on blood cultures, because most fungi don't. And we know this isn't just a fungus, this is actually a yeast. So we break down fungi into yeast, dimorphic, and molds. And the examples of molds include Aspergillus and Mucor. There are many, many dimorphic fungi. JAS has made Blasto famous, and others have made Histo and whatnot famous too. But the 3 yeast that we think about are PJP, which is a pulmonary disease, Candida, and Cryptococcus. And 2 of those 3 things, Candida and Cryptococcus, grow on blood cultures. Patients with cirrhosis are at risk for both candidemia and for cryptococcemia, both of them. It is a very common mistake that we hear about where a patient who has cirrhosis, a patient who has 1 out of 2 blood or a patient who has yeast in their blood cultures is assumed to have Candida because Candida is much more common than crypto, only for us to later learn that the patient has Cryptococcus. Now you may wonder, wait, Cryptococcus, I strongly associate that with HIV. Is this the right patient context to think of it? And the answer is absolutely yes. Outside of HIV, cirrhosis is by far and away the most common common cause of disseminated cryptococcus. You may then also say, wait, hold on, I associate cryptococcus with dissemination to the brain. You just spent 10 minutes in the last aliquot talking about how the patient doesn't have any brain symptoms. And that's where I think crypto can be very, very sneaky and cause very subtle brain symptoms for a long time, just a mild low-grade headache. But more importantly, patients with cirrhosis who have cryptococcus may present differently. And the way they present differently is they tend to have more peritonitis as a cause of cryptococcus and tend to have more skin disease. So here you are saying, well, hold on. This patient has abdominal pain. We weren't able to tap her, and she has skin nodules. Could that be cryptococcus in her belly and in her skin? And the answer is absolutely yes. The good news is if you call the microbiology lab, they can tell you based on the size of the yeast that's growing, if it's likely to be crypto or not, because crypto is a massive yeast. It's very, very big, much bigger than Candida. And so they can often tell you what they think is going on. Of course, a serum cryptococcal antigen or a CRAG can also help you because a CRAG is very likely to be positive in a patient with cirrhosis. So I'm pretty worried about the possibility that this represents cryptococcus. And why am I even more worried is because the patient has been started on micafungin. Micafungin is a great echinocandin that has great treatment against Candida, but has no activity whatsoever against cryptococcus. And so I think we could be in a situation where we're being misled to think this is Candida, a much more common cause of yeast in the blood. But the context here should make us wonder, hey, is this yeast actually Cryptococcus? And the echinocandins like mycofungin have no activity against Cryptococcus. It's 1 out of 2 only, and it may turn out to be Candida. And the question is, does Candida fit the rest of this picture? And the answer is not so much. So let's analyze the rest of this picture. She's got nodules. She's got painful nodules on her forearm. Nodules are deep space processes affecting the dermis and the fat layer of the skin. Very, very rarely, they can be the result of a primary dermatological issue, like prurigo nodularis, nodules that develop from itching, but they often represent a metastatic disease to the skin. So the truth is, most of the time when we see a rash, we often suspect that it's a local problem, a local infection like tinea, a local issue like contact dermatitis. And very rarely do you ever see a look at a skin rash and say, oh my gosh, this is a systemic issue affecting the skin. When you see nodules, unless the patient is itching a lot or has some other rare dermatological conditions, you should make the assumption that this is a systemic disease infiltrating the skin. In other words, nodules are like the alkaline phosphatase of the skin. They indicate infiltration into it. And the question is by what? And the answer is 2 different things. Granulomatous disease processes love to infiltrate the skin, be it sarcoid and an autoimmune granulomatous disease, or the whole list of granulomatous infections, including Cryptococcus. It's also possible that patients with metastatic malignancies can infiltrate the skin and cause nodules, but we don't have that context right now. So what am I most worried about now? I would be most worrying about misattribution of this yeast to Candida when it is crypto. If it turns out to be Candida, then I'd be like, okay, this is candidemia in a patient with cirrhosis. We've seen that. We'll treat that. Does that explain everything? And I worry that it might not explain the skin and it might not explain the abdominal pain. So we would have to do a lot more thinking if this yeast turns out to be Candida. I think it would make a lot more logical sense in this case for this yeast to turn out to be crypto, which will open the doors for many other issues, including sampling her CSF. But I think it's so key to know what this yeast is and not to assume that it's Candida. Alrighty, you said you wanted one more round of data and then breakout. Is that right?
Yeah.
Okay. All right. Let's do it.
Okay. Very, very short little aliquot. So she has a serum crag that comes back negative. And I don't know, remember if we called the micro lab or not. I remember ID, like, oh, they always talked to the micro lab, and there was something about like they didn't have a report back for us right away. And so she then noted that this rash, there was like a new looking rash that had appeared like on her hands and on her neck and torso and like her leg. And I can show you a picture of that, and then we can chat in breakout room. Let me find the share screen.
I'm so
okay.
Whoa.
Okay. So this is the kind of secondary rash that developed. And, you know, we had initially, like, we felt the nodules and we were like, it's like where she, like, right where she was like rubbing the CGM like against her body. So the CGM was removed, and that seemed to like make that rash behind her arm like get a little better. It looked more like bruising to us. And so we were like, whatever. And then this rash appeared on her like hands and on her legs and on her neck. And so Durham was consulted for a biopsy, which is why you see the little markings on the neck lesion. It is painful. It is very painful. You touch it and she's like, that kind of stings, kind of burns. And it got worse. Like it didn't just it started just on her hand here, and then it just kind of spread.
Fascinating. Wow, what a case. You know what's really funny, guys, is Kara was like, I think you're gonna get this in the first 30 minutes. And let me just tell you publicly, I am absolutely clueless as to what this person I think it's gonna be an interesting case, but there's no way any human being is getting this case in 30 minutes. It's such a really interesting one. Thank you for for choosing to present it. Okay, you gonna say something?
Oh, she's still febrile.
Okay, all right. And is she hurting? Is she in abdominal pain or no?
It's only she tells the ID
Yeah,
doctors when they like do the thorough exam that it's only when she twists still, and we
I
like
see.
have a pretty benign abdominal exam as we trend
Okay.
it.
So your active problems are that your context is that she has cirrhosis from hepatitis D and B, and that she has ongoing persistent fevers. She has 1 out of 2 blood cultures growing yeast with negative cryptococcal antigen, and she has diffuse painful nodules. Is that a fair? Okay, cool. All right. Lovely people. Breakout rooms. If you can't join, no worries. Just hang back right here. But I highly, highly encourage you to join. Turn on your cameras, chat with each other, get to know each other. We'll do this for about 5 minutes, okay? And I will go to the bathroom. See you soon. All right. I don't see. Oh, there you are. Huh. Okay. I hope you guys had a good time. I think there's nothing like being able to really engage and share and connect with our learning and iron out our wrinkles and make progress. And uh, for me, I was doing so without the benefit of being able to do it with the incredibly wise Prof. Rez. And gosh, I'm really feeling that today. I really wish he was here. We would be having so much fun together. But anyway, I hope he's in REM sleep. Um, there's 2 threats to this case. There's understanding the clinical syndrome, and then there's understanding the blood culture results. And the blood culture results are very, very intriguing. Um, the first step with the blood culture results, to be methodical about it, is to ask, could this blood culture result be distracting us? Could it be a contaminant? And the answer to this in quite simple terms is absolutely not. You should never, ever, ever assume that any yeast of any kind is a contaminant. So we talked a lot about what yeast could be. And in the blood, when you're growing a yeast, you're either dealing with Candida or Cryptococcus. Um, and there is actually a small exception to that, and that's Fusarium. Fusarium is a mold that actually can in the body reproduce and have yeast and mold grow, and that can grow in blood cultures too. So this could be Fusarium, but the host for Fusarium is usually a patient with neutropenia, not cirrhosis. So when we see that we're trying to essentially have a battle between Candida and Crypto to understand the blood culture results, we know that Candida is much more common than Cryptococcus. And now we know that the patient's CRAG is negative, and that CRAG should really, really push us further away from Cryptococcus. And essentially, we're saying that this patient starts with a higher chance of having Candida, and a really good test for Crypto is negative. I think that's the best I can do with the blood cultures. What about the syndrome? How do we describe the syndrome? The syndrome is a febrile nodular syndrome of the skin in a patient with cirrhosis. The fever and cirrhosis should have us be prioritizing infection, infection, infection. And nodular infections that disseminate to the skin are of the granulomatous variety. And herein lies the clash with Candida. Candida does not do this, at least as much as Cryptococcus. So who wins? The blood culture results suggesting Candida over and over, or the syndrome prioritizing Crypto? And then that's when you have to say, well, hey, could the CRAG be falsely negative? And the answer is absolutely yes. In cases where such high burden of Crypto, you can get what's called the prozone phenomenon, where the CRAG is so high that it causes a false negative. And I think we only have a few minutes left, so I don't want to go through explaining that mechanism, but you should really look it up to understand it. It's called the prozone phenomenon. There are also many species of Cryptococcus that don't have the polysaccharide capsule that the CRAG tests. So there is the possibility of CRAG negative Cryptococcus. If we lean towards the blood culture result being Candida, we then have to explain a hectic febrile nodular syndrome through other means. And that other means is by invoking the possibility of a rare but important consideration, which is hepatitis B-induced polyarteritis nodosa. And that can cause fever, abdominal pain, and nodular lesions in the skin because it can cause a paniculitis or inflammation of the fat. So right now, I'm really, I think that this case will be completely cracked by knowing what the blood culture result is. If it's Canada, we have to find an alternate explanation for the skin lesions. If it's crypto, then we don't. And what would I do in real time? I would call the micro lab and really ask them to tell us morphologically what this looks like. And they should be able to distinguish the two morphologically. I would also repeat the CRAG and dilute it down to see if it becomes positive as you dilute the burden of the antigen. I think it would be a very tough call if I were the only person taking care of this patient, whether to broaden the patient to amphotericin to treat both Candida and crypto. And I'm so worried that this is a sneaky case of Cryptococcus that if I were alone, I probably would. But it's a tough one. It's a really tough one. I'm really curious to hear from you, Kara. What did you all do? How are you thinking about it? And ease my palpitations right now.
Dermatology cracked the case for us. So kind of a couple of things happened in tandem. Dr. Dan Minter, who's a dear friend of the podcast and of us here at UCSF, he was the transplant ID attending on the case with me. And he recommended broadening to amphotericin because of how much this looked like a cryptococcal infection, even though the serum CRAG was negative. And he went down to the micro lab and asked them to run diluted CRAG assay. In the meantime, dermatology called us and said, on staining, this woman has cutaneous cryptococcus. And we called ID right away, and Dan let us know that the diluted assay of the CRAG came back positive 1 to 160. And so in that setting, she was on amphotericin, and a kind of cascade of events happens next where you have to rule out CNS involvement of Cryptococcus. And so after much I remember consternation and a lot of drama, we got her an LP and it was positive for Cryptococcus. So she was shown to have disseminated cryptococcal infection with CNS involvement, but had to be placed because of that, like kind of petering AKI in the background, which had initially improved with some albumin, but then kind of like remained, got much worse with amphotericin. And so she had to be switched over to fluconazole. Yeah.
Oh, I think this is I'm obviously very biased. Like I think we all yeah, I think somebody near and dear to my heart is presenting this case, and I'm gonna have a great time anyway, but like this case is unreal. And to be honest with you, and Kara doesn't know this because I don't know this case, but this case is very familiar to me. And the reason it's familiar to me is not because I saw this patient, because when I was on LTU, this exact same story played out. It was a middle-aged woman. She didn't have Hep B cirrhosis, she had NASH cirrhosis. And I was, on LTU, like at least when I was a resident, you wouldn't cover the same person every day. You would just so I just hopped into her case at this exact juncture. And I didn't know anything at the time. And nothing that I shared with you I knew then. And I learned from that case just how important it is to call the microlab to try to identify. And I think what Derm did for you, I think the microlab can do. Because if you're growing the yeast on blood, there's nothing the dermatology did that the microlab can't do. And I learned from Dan later that Cryptococcus is such a massive yeast that one look by an experienced dermatologist, microbiologist, infectious disease doctor will be able to tell you in no time. But if you don't know that, which I didn't, I think this goes to show you how the heaviest thing in clinical reasoning is the current evolving syndrome. This patient is more at risk of Candida than crypto because of cirrhosis. In fact, now Kara will tell you this all the time. When patients with cirrhosis get sick, they could get put on empiric Candida treatment with mycofungin, empirically, without even Candida growing. That's how common it is. But even though the patient is at risk of Candida infinitely more than crypto, the syndrome is crypto, 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 crypto. So no matter what the person is at risk for, what is happening to them now is way more important and way more valuable, which is why when you're trying to solve a case, and now analyzing and understanding the foreground is the most important part. The background is just a sense of what the patient could have. The foreground is telling you what the patient currently has. And if you change this case and say the patient had recently on TPN, got steroids, and has eye symptoms suggesting of endophthalmitis, this is Candida all day, every day. But if you say the syndrome is spontaneous yeast in the blood with nodular lesions in the skin, I don't care how many negative crags there are and whatnot, this is crypto until proven otherwise. And I think it's really, really cool to add to my armamentarium the value that Durham can prove otherwise, because I didn't think of that in my case, and I didn't even think of that upon reflecting, but I'm glad that that lesson was reinforced today. It was really cool. How did you keep this case for me for so long? And two, what did you learn? What was your what was your experience like?
Yeah, I think we were so like wedded to how good the serum crag would be. And LTU, it's a very, very busy service. And so like, we try the micro lab once, we don't get an answer. We don't necessarily like think to ask infectious diseases, go down there and talk to them too. And ID was initially pretty convinced that this was Candida, like given that it was only 1 out of 2, none of her other cultures were growing yeast. Like they were just like, okay, we'll broaden into mica and cover her empirically. Also pretty wedded to the fact that I think the serum crag was negative, but like relearning about the proton effect, which we learn so often, I feel like in is it syphilis, right? That it can be recontextualized to like, I mean, any antibody assay is like is vulnerable to this, I'm sure. And so like, yeah, and then like the following workup was also really enlightening. I think knowing that like once somebody has disseminated crypto, like because it likes the CNS so much, you have to rule that out because it changes how you think about it. And she's still going to hepatology outpatient visits as far as I can see in the chart. So she was managed and was able to go home and kind of continue to live a life. I don't know if she got retransplanted. That was the one other thing, because that was why she like kind of revolved through the service. But yeah. And then also was reading a little bit more about how like you can have different cryptococcal species, like you were saying, that don't that fly under the crag, like the serum crag radar.
There's so many cool lessons, and I think the point that you were just emphasizing before the emphasis on the serum crag was like the frame of does she actually have decompensated cirrhosis, or does she have something else? Which I see Jimena made as her theme for. I love the themes that Jimena does, and I think just to emphasize that, like in retrospect, I anchor too much on the frame of decompensated cirrhosis, and I learned in talking with you all how important it is to use the lack of hepatic encephalopathy, which is such a common feature of decompensated cirrhosis, to say, hey, this is something else. And I think that certainly bore fruit today. Oh, amazing. Thank you so much for this awesome hour. I will pass the mic to you, Jimena, to take us home with the teaching points.
Well, thank you everyone for coming here, and thank you, Dr. Kara, for presenting this case. I'm a little bit biased because I love ID cases, so I enjoyed it a little bit more than I should probably. So to start with the teaching points, this time I decided to separate it in the hepatitis pearls that Rabih shared with us. Remember that Hep D needs Hep B to produce infection. We can have two types of infection. Co-infection, that it's usually less severe than superinfection. It tends to be worse. Hep D has a strong correlation with injection drug use in the US. So that's a risk factor to take into account. And also remembering that superinfection has a higher rate to cause acute liver failure and cirrhosis progression. So this patient should be monitored more closely. Then with the cirrhosis pearls, we learned that patients with cirrhosis may not present with the regular signs and symptoms of infection because they're not able to mount an immune response as a patient without cirrhosis. And also they can get altered mental status due to hepatic encephalopathy. So an easier way to approach these cases is to approach it as a decompensated cirrhosis case. Also, other typical signs that we had in this case from decompensated cirrhosis was the fever because of what we talked about, the abdominal pain, and also the lack of altered mental status, which wasn't expected in this case due to the degree of liver damage that this patient had. Also, patients with cirrhosis have a higher risk for Cryptococcus and Candida infection. And another really cool thing that we learned is that Cryptococcus is highly associated with cirrhosis. So that's another thing that we should have in our differential diagnosis. Then we're moving forward with ID pearls, and we were reminded that echinocandida is great for Candida, but has no activity against crypto. And when it comes to skin nodules, it is expected to be caused by crypto, but not by Candida. And then other pearls that we learned about nodules are that they usually represent a metastatic disease in the skin, which is infiltration, and they're rarely represent a primary derm condition. And granulomatous diseases and infections love to infiltrate the skin. And with the last teaching point I want to leave you is that this case, the approach changed a lot when we think about decompensated cirrhosis. And in this case, it was key to differentiate if we were actually dealing with a decompensated cirrhosis or with a compensated cirrhosis associated with another pathology. And that was like a pivotal point to understand the presentation of this patient.
You should look at the chat if you haven't already. This is so true. I'm really, really sad that this is your last sequential RLR teaching point event. We will miss it. You're just taking your teaching to another level. Thank you so much. It's just top notch as per usual. All right, y'all. I hope you have a wonderful Friday, and we hope to see you next time. Thanks for hanging out. Bye.